Sean todos bienvenidos a este webinar que es el tema de introducción a la salud global y cobertura universal de salud, tanto retos y oportunidades. Nos van a acompañar el día de hoy dos expositores que han trabajado muchísimo en temas de salud global. Vamos a irlos analizando cada uno de ellos. Estamos con el doctor Héctor Carrasco y el doctor Barnabás Alayande. Sí, les voy a comentar un poco de su background. El doctor Barnabás Alayande es un cirujano general que está trabajando en el Centro de Cirugía Global y Equidad. Él también es profesor de la Universidad Global de Salud Global y Equidad y su formación de base es medicina y cirugía, teología, todo lo que son manejos de negocios y el manejo quirúrgico a nivel global. Ha estado expuesto y ha trabajado dentro de los procesos de los sistemas de fortalecimiento quirúrgico en el África subsahariana, tanto en la parte de desarrollo como en la contextualización y todo el proceso de formación curricular de los profesionales y también de los posgradistas a nivel de todo lo que es la formación quirúrgica. Ha trabajado en todo lo que es trauma, como el cuidado del trauma y los cuidados seguros dentro de la parte quirúrgica, así como los factores humanos dentro de la formación de educación. Bienvenido, Dr. Barnabás. Muchas gracias por acompañarnos. Thank you, Dr. Barnabás, for being with us today. Y el doctor Héctor Carrasco, que es director igual de del Departamento de Salud de la Universidad de Tennessee en la parte de equidad y salud. Él ha sido miembro del comité de apoyo o de consulta del Estado en la parte de salud y equidad. Ha sido designado también por varias formaciones que ha tenido en la parte del tecnológico de Monterrey y también en la investigación del St. Jude, área de Children's, perdón, del área de búsqueda. Ha sido reconocido como miembro de los investigadores del Sistema Nacional de México. Tiene amplia experticia en la parte de salud y equidad, en cuidados de atención primaria, en uso de sustancias y en salud comunitaria. Ha trabajado con áreas de gran impacto, con programas de alto impacto en temas de adicciones y prevención de sobredosis, una iniciativa que se ha llevado a cabo en Tennessee. También ha servido dentro de la comunidad como director en varios programas de salud comunitarios y en la parte de salud en el área de Chiapas, México. Muchas gracias por acompañarnos el día de hoy, doctor Héctor. Es un gusto para todos nosotros el poder estar con todos ustedes y compartir un poco de esto que significa la salud y la equidad global dentro de todo el proceso de salud. Queremos agradecer por todo el trabajo que se ha llevado a cabo con la Corporación Latinoamericana para la Salud. Esta es una corporación con la que hemos formado un partner, un socio dentro del área de Ecuador y la idea es trabajar dentro de procesos de equidad en el fortalecimiento de todo lo que es la parte quirúrgica a nivel nacional e internacional en todo lo que es el proceso de Latinoamérica. Agradecemos a su directora ejecutiva, María José García, quien nos acompañó también el día de hoy. ¿Me confirman si podríamos pasar ya la presentación? Cami, para poder iniciar.
Ya, Doc, ya está compartiéndose.
Muchísimas gracias. Entonces, iniciaríamos, Héctor, por favor, con usted.
Excelente. Pues, estimada Carla, un placer. Gracias por esa amable presentación. A María José García, de la Corporación Latinoamericana para la Salud, muchísimas gracias por la invitación. Y bueno, es un placer también compartir este podio con el doctor Barnabás, colega de cirugía global, ¿no? Yo trabajé algunos años para Partners in Health, pero desde México. Entonces, it's such a pleasure to share this panel with you all. Entonces, a mí se me pidió hablar sobre el tema de equidad en salud y entiendo que no tenemos mucho tiempo, entonces me gustaría ir compartiendo algunas de las slides y va a haber un punto donde podamos tener más una discusión. Pero yo titulé esta charla Reimaginando la equidad en salud, el futuro. Hay que pensar en el futuro, hay que atrevernos a soñar qué puede ser el futuro. Entonces, la siguiente slide. Yo voy a empezar esta charla con dos historias. Luego voy a hablar sobre una teoría de cambio que he ido desarrollando en el transcurso de los años trabajando en México. Soy director de equidad en salud en el estado de Tennessee, en Estados Unidos. Manejé un programa, el programa más grande de adicción a opioides en el estado. Entonces, y también me tocó trabajar mucho en comunidades rurales en Chiapas, entonces tengo esa perspectiva de primer, tercer mundo y creo que el haber nacido, crecido en México, creo que me da una perspectiva también para hablar sobre teorías de cambio desde el sur y también algunas contradicciones que yo he visto que limitan la salud como tal. Entonces, siguiente slide. La primera historia empieza con el doctor Roblero, un médico que se acaba de graduar de la Escuela de Medicina, de su servicio social, que después de graduarse se va al estado más pobre de México, Chiapas, justo en el borde con Guatemala. Siguiente slide. Llega a una comunidad muy pobre que se llama La Soledad. Es una comunidad de 1,500 habitantes, 56% de la población vive en pobreza extrema. Es una comunidad donde la gran mayoría de las personas se dedica a producir café. Es una zona caficultora. Y aquí se produce uno de los mejores cafés del mundo. De variedad arábiga, Starbucks, Green Mountain, todas estas corporaciones grandísimas tienen subsidiarias y compran café en la región. Pero estas personas que producen este café son tan pobres que no pueden tomar el café que producen. ¿Por qué? Porque no lo podrían pagar. La siguiente slide. Entonces, el doctor Roblero llega y lo primero que nota es la escuela. La escuela en La Soledad se ve más o menos así. Y bueno, se pregunta, ok, vengo de una escuela privada en México y así es como está la escuela, ¿cómo irá a estar mi clínica, no? Siguiente slide. Cuando llega a su clínica, el doctor Roblero nota que la verdad es que la clínica se ve bastante bien. Le pregunta a la gente por qué esta clínica se ve bien y le platican la historia de cuando amarraron al presidente municipal para que les construyera la clínica que les había prometido 2 veces seguidas y no les había cumplido, y el gobernador terminó poniendo los recursos para que le construyeran esa clínica. Entonces la clínica del doctor Roblero realmente es muy bonita. Siguiente slide. El doctor Roblero inmediatamente empieza a trabajar y a ver pacientes. Y uno de los primeros pacientes que vio fue Esdras. Esdras, un niño con desnutrición crónica, que la primera vez que el doctor Roblero lo vio fue porque el doctor Roblero estaba durmiendo en la farmacia de su clínica y llega una pareja a las 2 de la mañana a tocar la puerta. Doctor, doctor, doctor. Se despierta, va a la puerta y encuentra una pareja con un niño en los brazos. Le dice, doctor, está muy mal nuestro hijo, lo revisa, se da cuenta de que sufre de nutrición crónica, siguiente slide, y empieza a ver qué es lo que tiene el niño, ¿no? Lo empieza a revisar, a lo mejor muchos de aquí son médicos, y me dirán un poquito qué puede ser, ¿no? La siguiente slide. Entonces, él ve un niño de 1 año y medio de nutrición crónica, falta de apetito, tiene tos y sensación de calor. Cuando lo revisa, se da cuenta que tiene fiebre, taquicardia, disnea, es decir, le falta el aire. Cuando lo ausculta, encuentra crepitancias en el lóbulo anterior superior izquierdo. Y él dice, ¿sabes qué? Esto, en la escuela de medicina yo aprendí que se llama neumonía. Seguramente es adquirida en la comunidad y seguramente es por ese bicho que se llama el Streptococcus pneumoniae. Y le da una dosis de ceftriaxona y le hace la referencia al hospital más cercano y dice, aquí se acabó mi trabajo, váyanse a descansar, y dice, va a dormir el doctor Roblero, un paciente de 1 por 1, ¿no? Dice, así vamos a cambiar el mundo. Entonces, al siguiente día, siguiente slide, al siguiente día el doctor Roblero empieza a ver su lista de pacientes y la enfermera le dice, oiga doctor, escuché que Edras no se fue al servicio de urgencias, que no sé cuándo usted lo refirió, que sigue enfermo y que está en la casa muy mal. El doctor Roblero inmediatamente para la consulta, se va corriendo a la casa de Edras, está en la casa de Edras, y desde la distancia ve un montón de gente alrededor de la casa de Edras, ¿no? Hay mujeres llorando. Obviamente él está preocupado, no sabe qué hacer. Junto con algunos auxiliares de salud, toman a Edras, se lo llevan al hospital, lo intuban, le ponen antibióticos intravenosos y Edras se salva. Pero eso pone mucho al doctor Roblero a reflexionar, ¿no? El recién graduado de la escuela dice, ¿en qué fallé? ¿Qué me falló que esto sucedió con Edras, ¿no? Edras estuvo a punto de morirse. Entonces, se pone a reflexionar, siguiente slide, y se da cuenta que más de la mitad de los niños de la comunidad de La Soledad tenían desnutrición crónica. Y él dice, si voy a cambiar el futuro de esta comunidad, tengo que entrarle a desnutrición. Entonces empieza a reflexionar y dice, bueno, ¿cómo un médico puede atacar la desnutrición crónica, ¿no? Y llega a la conclusión, siguiente slide, de que lo que tiene que hacer es educarlos sobre esto que se llama el plato del bien comer. Los que hacen nutrición aquí a lo mejor saben un poquito de esto, ¿no? Ustedes agarran un plato, la mitad van a ser verduras y frutas, una cuarta parte va a ser una proteína saludable como pescado, carne, etcétera. Y luego una cuarta parte, sobrante, van a ser granos. Por ejemplo, puede ser pasta, puede ser arroz, etcétera. Entonces él dice, lo que hace falta es enseñarles el plato del bien comer para que no haya desnutrición en la soledad. Adelante. Y él agarra a todas las mujeres que tienen niños desnutridos, los mete en unos talleres de educación y 2 veces por semana les da clases. Al final de 2 semanas, el doctor se encuentra solo. Y una abuela le dice, doctor, usted nos viene a enseñar lo del plato del bien comer, pero ¿cómo se hace un plato del bien comer cuando no tenemos carne, cuando no tenemos pescado, cuando no tenemos huevos, cuando no tenemos nada de lo que usted nos viene a hablar? Aquí tenemos tortilla, a lo mejor tenemos arroz y de vez en cuando tenemos frijoles y carne, pues raras veces, ¿no? Entonces, obviamente el doctor se da cuenta de que algo le falló. Se va otra vez a pensar y llega con una solución muy interesante. Siguiente slide. Esta se llamó la incubadora comunitaria, una nueva tecnología que a través de calor producido por esos focos y un termómetro que quitó de su clínica y huevos, iba a producir pollos para dárselos a las familias con niños desnutridos. Ese era el sueño, ¿no? Y el doctor Roblero empezó a hacer diferentes diseños para ver cómo producía pollos porque se dio cuenta de que pollos era lo que iba a cambiar el futuro. Esta incubadora no funcionó. Después de 3 meses, el doctor Roblero la echó a la basura porque no funcionó para el propósito. Hay muchísimas cosas que los médicos no aprenden en la escuela de medicina sobre pollos. Siguiente slide. De ahí, el doctor Roblero dice, ¿sabes qué? Yo no conozco nada de pollos. Yo no sé nada del plato de bien comer, pero sí le puedo enseñar a la gente a producir su propia comida a través de jardines comunitarios. Entonces el doctor hace un jardín enfrente de su clínica para enseñarles a los pacientes cómo producir su propia comida. Después de 3 meses, siguiente slide, el doctor Roblero termina con 3 tristes zanahorias y una lechuga. Es todo lo que produjo en el jardín. ¿Por qué? Porque los pollos llegaban y le comían las plantitas, porque los niños jugando ahí en la clínica de repente llegaban y le pisoteaban el jardín y por un montón de razones más. Entonces, estrategia que tampoco falló, que tampoco funcionó en los jardines comunitarios. Siguiente slide. Después dice, ¿sabes qué? Yo no sé nada de pollos, yo no sé nada de jardines, yo no sé nada de plato del bien comer. Puede traer a los expertos en inseguridad alimentaria. Una organización que se llama Heifer International, ¿no? Que son súper expertos en este tema de inseguridad alimentaria. Llegaron, tuvieron una reunión con toda la gente y llegaron a la conclusión de que efectivamente la manera de resolver los problemas de nutrición en esta comunidad era a través de gallinas. Entonces, siguiente slide. Un día, el doctor Roblero se encontró prescribiéndole a cada niño con desnutrición 14 gallinas ponedoras y un gallo grande. Para el doctor Roblero, este era el sueño de su vida, que como médico le pudiera prescribir comida a sus pacientes era algo más allá de ensueño, ¿no? Entonces, el día que llegaron, al siguiente slide, el día que llegaron los pollos, toda la gente en la comunidad estaba feliz. Había fotos de gallina, había fotógrafos profesionales tomando fotos, las familias recibiendo las gallinas llegaban, gallinas se iban, era una cosa impresionante. Farmers and Health puso estas fotos en su página principal, Heifer International puso también estas fotos en su página principal, todos estaban felices, ¿no? El siguiente slide. Y este era uno de sus proyectos que seguía todos los principios de desarrollo social, colaborativo, culturalmente apropiado, recursos locales, etc. Dirigido por expertos, o sea, tenía varios de los principios que queremos en un proyecto de desarrollo social. A la siguiente semana, siguiente slide, los pollos empezaron a morirse de alguna enfermedad. Newcastle virus de Newcastle, ¿no? Empezó y mató la mitad de los pollos que habían llegado nuevos. Y no solo eso, el virus se salió de control y terminó matando una tercera parte de todas las gallinas en la comunidad de la Soledad. Una tercera parte. Estas eran miles y miles de gallinas muertas. Siguiente slide. Y ahora, la gran parte del tiempo que las madres de estos niños con desnutrición pasaban era enterrando estas gallinas, haciendo hoyos y enterrando estas gallinas que se estaban muriendo en números incontrolables. En este punto ya el doctor Roblero está muy triste y dice, ¿qué ha pasado? Siguiente slide. Y lo más triste es que, como ustedes se pueden imaginar, después de varios proyectos, este fue otro de esos proyectos que no tuvo éxito. Siguiente slide. Y la pregunta aquí para ustedes es, ¿quién era el doctor de los pollos? O el doctor Roblero. Ese era yo, ¿no? Ese era yo después de graduarme de la escuela de medicina. Siguiente slide. Siguiente slide. Bueno, ahora, nos vamos a mover desde Chiapas hasta el estado de Tennessee. Nos vamos a mover a un lugar que se llama Palmertown, Tennessee. Es un pueblito rural en Estados Unidos, donde en los 70s, en los 80s, estos pueblos rurales les estaba yendo de maravilla. Esta es una cooperativa, en ese pueblito tenía una cooperativa de agricultores, donde los agricultores llegaban, ahí ponían todo lo que producían en el año y de ahí empezaban a venderlo, ¿no? Esta es una tienda de muebles como roperos, camas, sillones, etc. Y esta, que está aquí a la derecha, es donde la mayoría de la gente vive en Palmertown, Tennessee, en algo que se llama casas móviles. En este pueblito creció Anthony. Anthony tenía sueños de ser rico en los 80s, cuando él nació, y lamentablemente por la globalización, la fábrica que movía la economía en este pueblito, una fábrica de Nissan, terminó yéndose a Aguascalientes, México, y dejó este pueblito sin que hubiera un motor para la economía local. Entonces, todo se fue en picada, muchísima pobreza. El padre de Anthony terminó con adicción al alcoholismo. Y Anthony, a los 17 años, dijo, ¿sabes qué? Yo no voy a aguantar violencia doméstica, abuso, me salgo de mi casa, empiezo a trabajar en una constructora para donde hacían edificios. Una vez se cayó desde el segundo piso hacia abajo, terminó en el hospital, le prescribieron oxicodona y después, oxicodona es un opioide que es muy adictivo. Y después de algunos meses, Anthony tenía una adicción a la oxicodona. Entonces, la primera vez que tuvo una sobredosis por oxicodona fue afuera de un Walmart y luego de ahí estuvo en la cárcel un año por robar una tienda. Después, en diciembre del 2022, cuando todas las familias celebraban Christmas o Navidad, Anthony tuvo una sobredosis debajo de un puente y fue encontrado 2 días después. Este tema, este caso es típico de la epidemia de sobredosis en Estados Unidos. Ahora ustedes me preguntarán, ¿cómo están vinculados lo que pasó con Esdras en Chiapas y lo que pasó con Anthony en Estados Unidos? Vamos a pasar a la siguiente slide. Cuando yo empecé a trabajar en Tennessee y cuando trabajé en Chiapas, me di cuenta inmediatamente de que hay algunos abordajes muy limitados cuando se trata de abordar temas de salud. Número uno, cuando uno se enfoca nada más en lo biológico, es decir, lo que hizo el doctor Roblero inicialmente con Esdras, prescribirle antibióticos y olvidarme del problema, ese es un abordaje biológico que nunca es suficiente. O algunos le llaman hospitalocéntrico, reduccionista, biologista. Hay muchas maneras de llamarlo, pero al final es lo mismo. Prescribirles medicamentos a estas enfermedades no es la solución. Cuando nos enfocamos en querer cambiar el comportamiento, por ejemplo, nos enfocamos en decirle a la gente, usted tiene que hacerlo del plato del bien comer, cuando ni siquiera sabemos las condiciones socioeconómicas de la familia, ese tampoco es suficiente. O cuando nos enfocamos en un abordaje tecnocrático, donde decimos, yo voy a crear una incubadora para resolverte el problema, tampoco es suficiente. Y el filantrocapitalismo, que es cuando agarramos a empresas grandes, que como parte de su programa de responsabilidad social dan donaciones, eso no nos va a resolver los problemas. Y esto lo mismo yo lo veía en el tema de adicción a opioides cuando estaba trabajando en Tennessee. Abordajes que son efectivos a lo mejor para algunos casos, pero nunca, nunca suficientes para resolver los grandes temas de salud que tenemos. Siguiente slide. Entonces, lo que yo estoy pensando aquí es, hay diferentes teorías que dicen cómo vamos a resolver los problemas de salud. Una teoría es esta, determinantes sociales, nacido muy eurocéntrica, muy de, pues si pensamos en Esdras, ¿qué es lo que está pasando con Esdras? No, pues tiene estilo de vida, ¿por qué? Porque las condiciones así lo quieren. Es un tema muy interesante de los determinantes sociales, porque no aborda algunas cosas. Por ejemplo, no habla sobre cambio climático, no habla sobre discriminación o racismo, no habla sobre cómo el individuo puede cambiar esas condiciones que lo rodean. Es muy determinista. Es decir, todos esos determinantes están arriba del individuo y el individuo los tiene que soportar y enfermarse en consecuencia, ¿no? Siguiente slide. Entonces, yo he pasado algunos años pensando en estos diferentes teorías de cambio que nos dicen cómo se producen las enfermedades. Cuando yo llegué a Tennessee, empecé a contratar expertos para que me dijeran qué hacer con este tema. Y me decían, pues mira, Héctor, lo que tienes que hacer es enfocarte en algo que se llama caregiver involvement. ¿Qué quiere decir esto? Vamos a hacerle que los padres pasen más tiempo con sus hijos, porque la manera de producir inmunidad cerebral a las adicciones es con alguien que te hable. Yo decía, pero ¿por qué los padres no tienen tiempo de compartir, de pasar tiempo con sus hijos, no? Y ya cuando empiezas a escarbar un poquito del por qué, te das cuenta que la gente está sobreviviendo y no tiene tiempo. Entonces hay muchísimo trauma y mucha adversidad cuando están creciendo en esos hogares, sobre todo rurales, pobres. Hay muchísima trauma y muchísimo abuso, ¿no? También. Siguiente slide. Entonces, con los años, yo he estado pensando un poquito más qué nos ofrecen las ideologías del sur y las teorías del sur para pensar en cómo se produce salud y cómo se produce bienestar. Y el mejor marco es este. Es este que, de hecho, lo escribió un profesor de Bolivia, Jaime Braille, y esto es una adaptación de ese marco, ¿no? Que yo lo hice un poquito diferente, pero básicamente no lo voy a explicar mucho aquí porque no nos falta tiempo, pero al final es, primero, todo empieza con el individuo a nivel individual y hay diferentes círculos concéntricos, pero todo se une al individuo y el individuo es parte de todo. Es decir, el individuo puede cambiar cada uno de esos círculos. Esto es algo muy importante que el marco de los determinantes sociales no lo ofrece. La otra es, agregamos la naturaleza, que si no tenemos naturaleza y no tenemos medio ambiente, si no cuidamos del planeta, todo lo demás no importa. Número 3, ideologías. Las ideologías son básicas para decidir qué sistema de salud nos vamos a prescribir, cómo vamos a vivir. Y hay ideologías que son que son tóxicas, ya hay ideologías que nos ayudan a construir como sociedad, ¿no? Por ejemplo, cuando pensamos en la meritocracia o en el individualismo, pues vamos a terminar con una sociedad muy distinta a que si pensamos en el bienestar colectivo y la solidaridad. Entonces, las ideologías nos ayudan a articular la sociedad en la que vamos a vivir, las comunidades, las instituciones que vamos a tener, sistema de salud como una institución también. También si vamos a tener discriminación o soledad o pertenencia. Y a nivel individual, todos esos arreglos llegan y terminan produciendo salud y bienestar o enfermedad y sufrimiento. Siguiente slide. Entonces, muy importante aquí es, hay arreglos que son muy limitados, que yo se los presenté antes, teorías que son muy limitadas cuando se trata de entender la salud. Y conclusión número 2, tenemos que pensar en cuál es su teoría de cambio. Yo tengo entendido que ustedes están en formación y que están tratando de articular cómo pueden moverse hacia la salud global. Y es muy importante tener una teoría de cambio adecuada, si no, el impacto de todo ese trabajo que ustedes hagan va a ser muy limitado o van a tener consecuencias indeseadas. Siguiente slide. Ahora, alguien muy interesante que ha pensado mucho sobre cómo articular el cambio es Paulo Freire, el educador brasileño, ¿no? Su libro, La pedagogía del oprimido, es uno de los grandes libros que les recomiendo mucho a todos ustedes. Pero él decía, es que como humanos, decía, nosotros estamos para transformar el mundo, pero necesitamos una educación que sea liberadora, ¿no? De freedom education, ¿no? Y él hablaba para llegar a esto que él le llamaba la conciencia crítica, que era lo que todos como humanos debíamos aspirar. Hay algunas fases. Hay una fase 1 donde empezamos a agarrar conciencia y fase 2 es donde nos movemos a la conciencia crítica. La fase 1 empieza cuando hay diversidad y hay un incidente crítico, le llamaba él. Por ejemplo, ustedes van caminando por la calle y se dan cuenta de que hay mucha gente sin casa. Eso ocurre en Estados Unidos, ¿no? Un montón de gente sin casa, los homeless. Entonces, empieza a haber tanta gente sin casa que empiezas a reflexionar y dices, oye, esto está mal. Y luego empiezas a ver que hay gente que está trabajando en este tema y empiezas a actuar junto con ellos y así es como llegas a la conciencia crítica. Es decir, cada uno de nosotros tiene incidentes críticos, a lo mejor una vez por semana, a lo mejor una vez al mes, pero esos incidentes críticos le hablan únicamente a ustedes. Son muy personales porque son muy emocionales. Piensen en algo que les haya dado coraje. Esos son los incidentes críticos. Y cuando uno empieza a unirse a un grupo de gente que está trabajando en el mismo tema y empieza a actuar en ese tema, es cuando uno empieza a ganar la conciencia crítica, que es un proceso de reflexión-acción. Siguiente slide. Ahora, rápidamente, yo sé que tengo muy poco tiempo, déjenme hablar sobre algunos arreglos muy opresivos que he visto, que usando el marco que ya les hablé desde anteriormente, estos son los países responsables del cambio climático por tamaño. Y solamente estamos hablando del primer círculo que era naturaleza, ¿no? Siguiente slide. Y estos son los países que van a estar en riesgo por el cambio climático. Entonces, si se dan cuenta, los países que nos produjeron el cambio climático, Estados Unidos, Francia, Inglaterra, todos estos, la revolución industrial en Inglaterra empezó hace 200 años, ¿no? Por ejemplo, México se acaba de industrializar apenas hace 40 años. Entonces, ¿quién es más culpable? ¿El Reino Unido o México? Juntos debemos hacer las mismas actividades o unos tienen que pagar más, ¿no? Entonces, pero fíjense, todos los países nuestros, pues la van a ver más difícil. Siguiente slide. Ahora, desde el punto de vista político, esta es la composición del gobierno federal en Estados Unidos por clase social. Y aquí lo único importante es reconocer que la clase trabajadora por ingreso es casi la mitad de la población de Estados Unidos, pero cuando ustedes empiezan a ver el gabinete del presidente o el Senado o la Casa de Representantes, que es el Congreso, se dan cuenta que la clase trabajadora no está representada. Siguiente slide. Ahora, cuando hablamos de inequidad, esto es cuánto del top 10% de la población tiene en ingresos y se van a dar cuenta que, por ejemplo, en India, que es uno de los lugares más desiguales, el 10% tiene el 55% del ingreso y así sucede en muchísimos otros países. Muy triste esta realidad. Siguiente. Ahora, cuando se trata a nivel de comunidad, este es un inmigrante en Estados Unidos. Esta es una compañera de Guatemala que nos llegó a una de las clínicas en el Departamento de Salud del Estado y que nos llegó con un asma por exposición, porque ella se dedicaba a pintar y aspiraba muchas sustancias tóxicas, ¿no? Entonces, obviamente, cuando ustedes comparan ella como inmigrante en Estados Unidos, yo como inmigrante en Estados Unidos, se van a dar cuenta que unos están mucho más expuestos a cosas que otros, por ejemplo, yo, ¿no? Siguiente slide. Y esta es el porcentaje nos lo vamos a brincar rapidísimo. Pero en general, sí me gustaría decirles que inequidad de género es un gran problema en Latinoamérica. Si ustedes se fijan, nada más 26% de las mujeres no están en educación, empleo o entrenamiento, cuando solamente 13% de los hombres no están en eso. Entonces es una gran inequidad. Siguiente slide. Y este es un estudio chileno súper interesante de cómo COVID causó más muertes cuando los estadios socioeconómicos fueron más bajos. Siguiente slide. Todo esto para decirles que cuando pensamos en equidad, hay que pensar en todos los arreglos que hacen que la gente sufra, que la gente se enferme. Y todos estos sistemas no son abstracciones, son gente tomando decisiones en el día a día que terminan dañando a otros. Entonces, si nosotros pensamos en cómo estos sistemas y cómo estas decisiones en alguna manera se meten en el cuerpo y terminan saliendo en forma de una enfermedad, esto es algo que se llama encarnamiento, ¿no? Encarnamiento de la profesora Krieger de Harvard. Y esto cuando pensamos en inequidades hay que ver por qué suceden estas enfermedades. Entonces, esta fue mi presentación. Espero que no me haya extendido y gracias por su atención.
Muchísimas gracias, doctor Héctor. Ha sido un gusto escucharle. Vamos a darle la palabra a Dr. Barnabas. Dr. Barnabas, can you hear me?
Yes, I can hear.
Okay, so we're going with you right now, and then we can make questions, and there's something we can talk after, okay?
Okay, sounds good.
Oh, thank you. Cami, ¿podemos ponerle las diapositivas? Muchas gracias.
Sí, Doc, ahí creo que se está compartiendo.
Sí, ya está. Está poniéndose en modo presentación, solo para
I
cambiar la
think I
modo.
can.
Sí. Okay, so it's all yours.
Thank you so much. So hello, everybody. Thank you so much for all the good work that you are doing. And I'd like to honor the previous presenter and those that have invited us to be here. I'm so grateful. And I just hope that this session is going to be helpful to you. I'm Barnabas Alayande. I've had an introduction, but I'm from the University of Global Health Equity, which is a university that is an initiative of Partners in Health, which has been talked about previously, that is focused on a new way of education instead of the regular things, just raising people for a general impact as physicians in the world. We're raising leaders. And our thought is that when we raise leaders who can strengthen systems, that things will get better little by little, and with their focus on the underserved and rural populations. So I've been asked to talk about an introduction to global health and universal health coverage. What are the challenges and what are the opportunities? Next slide, please. Next slide, please. Let me tap. Good. I have no disclosures, no relevant financial disclosures, but there are two things that I like to say. Of all the things I've been talking about, you can go back a slide. Of all the things we've been talking about, you notice that my work has largely been in sub-Saharan Africa and has been a lot around surgery, what we call global surgical care. So some of the examples I'll be bringing you will be African examples rather than South American examples, and they will be focused on global surgical care as well as the broader context of global health. Next slide. Okay, and based on the assignment I've been given, there are 4 core learning objectives at the end of this time. 1, we want you to be able to define what global health is, right? And then what universal health coverage is. Second, we need you to see what are the main challenges in implementation of universal health coverage. And third, we want to see, are there successful policies? Are there people, countries that are making this work? Are there innovative models that we can see in different regions that we perhaps can apply within the Latin America context? And then what is the role of health professionals in promoting this universal health coverage? So we just do this as a brief overview. Next slide, please. Okay, so let's start with the words of Dr. Jim Kim, also intimately connected with our Partners in Health network. He says, you cannot end extreme poverty if you are neglecting the investments in health and education that are so critical to economic growth. It's not just one thing. It is the health workers, hospital beds, it's making sure you can provide oxygen, it's going to the production capacity for vaccine, and all this has to happen very quickly. When you think global health, you shouldn't think very narrow in any way, because there are so many different components that come together to this construct, this thing that we call global health. And they don't get many things right and get those many things right together, then we probably are not going to achieve what we need in terms of health of the world. Next slide. So let's define what global health is and see what its scope is. Now, global health, before we can define it, we probably need to dig back into history to understand what the context of global health itself was. So very early efforts in what we call global health were before named tropical medicine. And then eventually it moved to humanitarian medicine. Then we talk about international health. And initially the emphasis on public, and then eventually we went to global health. But in defining what global health is, we need to think 5 things. You find many different ways that people try and define it, but we need to think 5 things. Number 1, we need to think geographical reach. Where does global health reach? Right? It focuses on issues that directly or indirectly affect health, but can transcend national borders. So global health is not necessarily just be local, but it must transcend. It's an issue that is health, and it may or may not transcend international borders or national borders. Number 2, we need to think about some kind of cooperation. People are working together, developing and implementing solutions that often require that we cross borders, we cooperate on a global level. So that's the second concept. The third is that you are dealing either with individuals or with populations. It doesn't have to be one or the other, right? It embraces both prevention in populations and clinical care of individuals together as global health. And then fourth, we're talking access to health. What do we mean by to health? We're saying that there should be health equity among nations. Anybody who needs healthcare should be able to get it. It's a major objective of what we term as global health. And then fifth is that there's a range of disciplines, many different people coming together. It's not just the doctor or the surgeon or the internal medicine physician, or even what we call the public health physician. It's also the engineers that are working on this, and it's also the nursing facilities, it's also the adjunct healthcare staff, the professors, the teachers, so that it's multidisciplinary. Go to the next slide. So next slide. So initially, when we go to the origins of what we now call global health, it was very narrow and focused on things like smallpox eradication, polio vaccination, and eventually it evolved to some kind of international health cooperation. But I want to say something about that. Next slide. That the roots of what we call global health are very colonial. Initially, it was very prescriptive, very exploitative. It was some stronger health systems dealing with a struggling, maybe low-income country or global south health. That's what we perceived as global health. And those frameworks still affect us today. Because initially it was about, help me tap 3 or 4 times. It was about, can you help me tap forward a few times? Initially it was about, oh, I don't want my soldiers to get sick. And then I don't want the colonialists that are now in this country extracting resources to get sick. And that was actually the origin of global health. Then eventually we were thinking, oh, I don't want malaria to move from this country that I'm colonizing into my country as the colonizer. So somehow the foundations of global health, if we really look at it, are very jaded. There's colonialism, there's racism, there's a lot of that is rooted within it. But over time, we have recognized this, and many people are pushing back and trying to make sure that this is actually an equitable endeavor. Next. Just keep pressing next. Great. So this is where we are today. And just pause on this slide. So this concept of public health, international health, global health, some have suggested, because there are many different definitions, but some have suggested those 5 things that I've talked about as core components of what we're talking about when we think global health, right? Okay, great. Next slide. So please go back one slide. Please go back once. Good. So what is the current state of global health? In looking to make healthcare available, in looking to cooperate across borders, in looking to make sure that everybody all over the world has some kind of access to health, when we're thinking global health, then there are key organizations we also really need to think about when we're thinking about issues that focus directly on health but can transcend national borders, things that have to do with development and implementation of solutions that require health solutions that require global cooperation, things that have to do with embracing, prevention for populations and then individual clinical care, when we're thinking of health equity for all people as a major objective, or when we're thinking of something interdisciplinary, multidisciplinary within and beyond health sciences, we need to think about major organizations. So we're thinking of the World Health Organization, UNICEF, the World Bank, and then major global health initiatives like the Sustainable Development Goals, Global Fund, etc. But somehow these things focus on certain issues that can really affect the health architecture across the world. So I told you, historically, we've looked at TB, AIDS, malaria, and they're still very important. But more recently, people are seeing that other things that are not infectious disease can also affect us at large scale. They are very important for the health of populations. And there's what we call the epidemiologic transition, where healthcare issues have moved from infectious diseases to now non-communicable diseases, things like heart disease, diabetes, cancer, right? And then when we're looking at global health, it's beyond just individual diseases. We're now thinking of health inequities. What should be available to populations that they do not have? What should be available to people that they have not gotten in terms of healthcare, right? And why? We're now thinking what they call social determinants of health, right? What are the things in the environment that affect the health of these individuals and populations? What are the things that have to do with things like poverty, location, rural versus urban, the availability of water, the availability of all these things play a part in health. And global health actually considers them and thinks about them. But I just want to quickly put in a plug. I told you I'm a surgeon. I work within Africa. I want to put in a plug for a few things. Next slide. Tap. A tap again. Next slide. Right. That sometimes, because of where we're coming from, we narrow our lenses in global health and think only about infectious disease, only about some kind of communicable diseases. But when we're thinking global health, we need to broaden our vision. And so I work within surgery. Surgery is not distinct from global health. In fact, global surgery is a subset of global health. But many times we neglect those kind of things. We say it's too expensive. We have excuses for why. But Paul Farmer once said, I was talking with him, he said, any health system that does not make place for surgery should not exist in this century, in this place, this time, because we're saying you can get this kind of care, but you cannot get this kind of care. So within the global health architecture, there is also the global surgery architecture. So let's think broadly and not just about malaria or TB or AIDS. It's about access to healthcare in every one of its dimensions. Every one of its dimensions. Next slide. We shouldn't let the way colonialism was thinking about healthcare, we shouldn't let it pervade our systems today. It's still there. So just to look at, these are the dates when individuals were colonized, and then they received their independence, just generally. Can you tap again? I want to lay another map on top of it. Just tap. Next slide. Good. So this is the workforce density of anesthesia. If you look at both maps, they're very similar, because colonialism has had an impact on our health and actually on global health as it does today. That's my case. Next slide. Yeah, good. And next slide. So this slide, I just wanted to emphasize that one more. I just wanted to emphasize that a lot of talk has gone into, oh, let's make healthcare available to everyone. And this from a surgery perspective, right? As far back as 1980, the WHO lead had said, oh, let's make sure surgical care is available to all people at a global surgery, in the global surgery field. Internists, Paul Farmer, Jim Kim, had come out as far back as 2008, rather, they had come out to say, look, surgery is the neglected stepchild of global health. We need to think more broadly about global health. But nothing was done until about 2015, when people started taking things seriously. Until today, there still are aspects of global health, not just global surgery, other aspects of global health that have been neglected and we're not paying attention to. Next slide. Now, if you looked at global health as a concept, what do we mean by universal health coverage? universal health and coverage, there is a concept, and this cube on this side, I can't draw here. This cube on this side gives us an idea of what we mean by universal health coverage. It essentially means all people can use all the health services that they need: promotive, preventive, curative, rehabilitative, palliative, everything that individuals need for health, of enough quantity to be effective while they don't experience financial hardship. So we're saying comprehensive access to any healthcare services that are essential, and then people are protected from financial risk while they're accessing that healthcare. Very, very simple concept, very ideal concept. I don't think anybody will say this is not something to be had for any country, that everybody can access comprehensive, essential healthcare services, and two, financial risk protection is there even while they're assessing that health service, because many people pay for healthcare and then they go into impoverishment. People pay for healthcare and then they're bankrupt. Some people pay for healthcare and then, but you want to protect people from that. And two, you want to make sure that they have all that they need. I'll tell you a bit about this cube in a couple of slides. So let's keep going. Next slide. So there are key components. The first is the concept of service delivery, meaning we can bring healthcare to individuals as a component of comprehensive healthcare, right? And the things under that will be primary healthcare, making sure that healthcare is available to the population, to the grassroots. That's the concept of primary healthcare, that it is. The World Health Organization first proposed it, the concept of primary healthcare, in about 1975. And then by 1978, there was this Alma Ata Declaration where they officially declared that let's bring healthcare to as close as possible to the individual. Let it go down to rural, not just some high-end hospital somewhere. Let people have immediate access to certain things that are basic, certain things that are essential, and that concept became that concept of primary healthcare. And it's really important when we're thinking about universal health coverage. It's not just one big hospital that people have to travel miles to get to. We're talking about core healthcare that is available. So then we're talking preventive services, not just curative services, because we can be curing. It's like there was a quote I heard about somebody who worked somewhere in South Africa and had been in the emergency room, always seeing patients stabbed. He says, I was always seeing this end, caring for them, but I had to go to the point where I wanted to stop the knife. We are not stopping the knife. We are just treating people who are injured, right? So preventive services are a core component of the service delivery in universal healthcare, and then emergency care. So these are core. When somebody has an injury, somebody has an emergency, medical injury, whatever, can the person get care? So that's service delivery. Two, financial protection. When somebody pays for healthcare, do they enter what we call catastrophic spending? Is it more than, for instance, 40% of what their earnings are, or 10% after they have paid for food? That kind of concept. Is that avoided when they are accessing care? That's a component. And then equity in access. Everybody should have access. Again, one of our mentors says, Paul Farmer, the idea that some lives matter less is the root of all that is wrong in the world. So everybody, vulnerable populations should receive care, right? People who don't have access to care because of the location, etc., they should receive care. Next slide. Next slide. So is there a global commitment to universal health coverage? Right? We know the United Nations has a Sustainable Development Goal 3. It says ensuring that healthy lives and promoting well-being for all ages. And within that SDG framework, if you look at target 3.8, it says achieve universal health coverage, including financial risk protection, access to quality essential healthcare services, and access to safe, effective, quality, and affordable essential medicines and vaccines for all. So the world seems to be committed to universal healthcare. But I wanted to put up an infographic showing you where we are now. In 2024, only 72 out of 195 countries worldwide have universal health coverage. That means about 70% of the global population has this, right? If you look at it population-wise, but 31% does not have. 69% thereabout has, 31% does not have. So if you look at the array of countries, you're seeing Canada, Mexico, Brazil, Algeria, Russia, China, and many of these are even nominal. India, Australia, South Africa. Many of these are actually nominal. Ghana has, Rwanda has, many of these. Even within the system, people still get catastrophic expenditure beyond the fact that we're saying healthcare is available to you. And today may not be the time to discuss that, but I think that there is some commitment, but there needs to be more. So how do we achieve universal health coverage? Next slide. Number one, healthcare financing. What the challenges really are money. That's what many people will say. There's insufficient funding in low middle income countries. Remember the Abuja Declaration there. There's a percentage of GDP that should be dedicated to by agreement, but very few countries even proximate or come near to it. And if you look at the LMIC versus HIC, high income country, low middle income country divide, you will discover that high income countries actually spend more. What we call developed nations or those in the global north, they spend more on their healthcare, and probably we see more results than many low middle income countries. So there's a big problem in low middle income countries, but we still are not putting our money where our talk is. So if we are committed, we need to pay. There's still high out-of-pocket costs for individuals, right? And why this challenge? I want to frame the challenge because one of the principles of universal health coverage is that it should be funded by government or para-government sources. Right? It may be donor funds, it may be social health insurance, and people have used taxes, insurance payments by individual citizens, and then that money is pulled together, brought together. And one other principle is that it should be unrelated to medical risk. If I am at risk, it doesn't mean I should pay more, right? So you shouldn't look for, oh, this person has a poor health status pay, or this one has a good pay. When we're talking UHC, the contributions should be unrelated to medical risk. And many times they are mandatory for sustainability. You have to pay. Yeah. And then eventually that pool can be augmented by other funding sources. So we have the challenge of financing because money is where the issue is. Next slide. So where do you put this money that you have received in terms of universal health coverage? So there are three dimensions of this square on the other side, on the right. That's to my right, maybe to your left. There is the issue of population. Who is covered? Who should we cover? Should we cover the young? Should we cover the old? I've noticed in some countries that they cover young people, energetic people in the workforce. But when they really need the universal health coverage, when they're really old, they say there's no coverage for them. Is that morally right? Is that something we should model? But you have to decide as a country. They're tough decisions, right? What is the population we are going to cover? What is the breadth? How wide should it be? The second thing is, what services are we going to cover? That are we going to cover cancer at all in this universal health coverage, or we just treat malaria, or we just treat TB, or we just treat anything big, surgery, maybe no, etc. We have to think about it. What services will be covered based on the pooled funds, right? And that's sometimes tough. That's what people call the depth. How deep is it? What do you want covered? And then the height of the coverage. What charges should patients incur? How much of the cost are we going to cover? Are we covering 50%, 80%, 90%? What is that? Now, the investment in and I'm putting this again from a surgical perspective. Many times we think, there's no money for universal health coverage. I want to challenge that paradigm. For instance, for surgery, as of 2015, we know from modeling that if we invested $350 billion, by 2030, we would have saved $12,300,000,000,000 just by that investment. So it's cost effective. Universal health coverage is cost effective, right? Investing in surgical care, investing in global health is cost effective if you look at it. And we say there is no resource. Now, what did we need again? $350 billion. I was just looking at it before this presentation, how much has been spent in the war, for instance, in Ukraine and Russia. And we find the resources for conflict. 152 billion in direct conflict. We will need up almost 500 billion for recovery from that. One side has spent 211 billion so far to equip, deploy, maintain. How much are we looking for the entire health system across the world, investing in global health, global surgery? 350 billion. But we have spent this amount in billions in conflict. I think we should not kid ourselves. There are resources for global health. We should make sure that we spend it appropriately. So this is just my thought around the issue of financing. Next slide. Next slide. So inequities in access. That's the second challenge, right? Because some people in urban areas, they get a lot of care. You notice our big hospitals, good primary health care, etc. But when you get to rural places, there's a challenge. And that's why, for instance, my organization is located in many rural places so that we change that paradigm. And we say it's a problem in equity in access. Wrote a paper 2021 looking at disparities in access to trauma care in sub-Saharan Africa. It was just a narrative review, but we saw very strongly that rural places, less care. There's that Pareto principle, kind of the inverse care law, where you have 70% of the disease in rural places, only 30%. That's one problem with universal health coverage. Next slide. Then human resource shortage. We don't have enough trained healthcare professionals, right? And there's a good paper by Agnes Binegwaho et al. Looking at human resource for health program in Rwanda, a new partnership. We lack trained healthcare professionals, many regions. And when we have them, most of them are in the city. In fact, up to 80-90% are in urban enclaves at the teaching hospital, and then nobody is in the rural places. Next slide. That's a challenge to universal health coverage. Then another challenge is the health systems or infrastructure. We have inadequate facilities and medical equipment and limited access to essential medicines and technologies. If you look in some places, you see lots of equipment, but they're not functional, right? There's many things there, but they're broken down. And the example I wanted to draw on this was of the drones that were the zipline program in Rwanda. Rwanda has many hills. Before you get blood from a central place to a rural hospital, patient may have died, maternal mortality, etc. And so they thought up healthcare infrastructure, drones that fly blood to the district hospital from central locations and just drop it down. And within 30 minutes max, you already have the blood that you need for this woman or for this person. So we have to think creatively about health system infrastructure. Next slide. And this is a big one. Next, it's the political and governance barriers. Many countries, there's lack of political will and leadership, because the question is, how will this cause me to be elected in the next 2 years, 3 years, 4 years, right? If it will, fine. Then the next person comes along and says, oh, I want to do something different. We need political will, and it will reflect in the budget. And sometimes there's corruption, mismanagement in health systems. I have a picture here of the Pan-African Surgical Healthcare Forum, 40 ministers of health, ministries of health represented by ministers and ministers' representatives, and some technocrats also came in to double that number thereabouts. And they were thinking of, what do we do? And that, for me, shows global surgery now is gathering political will on certain continents, certain places. I'm thankful for the work that's been done by former Vice President Alfredo Borrero and his team, and the work that is being done in Latin America now. There seems to be some political governance barriers being broken about universal health coverage, particularly global surgery. Next slide. So what are now the opportunities for advancing universal health care? One, we need to strengthen primary health care. We see primary health care as the foundation for universal health care. If you don't have care that is proximate to the people, that is close, if we don't integrate services for better health outcomes and start taking that care to where people can access it easily, then we are losing the opportunity for primary health care. If somebody has to travel so many miles to get to a health facility, it's a challenge. So one, strengthen primary health care. Number two, innovative funding mechanisms. Right, next slide. We need to start thinking about funding. And there's a way we have done it. But I think now people are thinking outside the box and saying there are other ways that we can fund healthcare, like public-private partnerships, like investments, right? Investment where people really get a return on their resources, but still it makes for universal health coverage, use of pooled funds, national health insurance. Donor support is not as sustainable. I'll show you some examples of countries that also incorporate that in, but there has to be some source of resource, some source of money, funding for health. In a few months, hopefully there's a new series that will be launched by the Harvard Program in Global Surgery and Social Change, which will look at different ways that countries can finance. And that money is available. For instance, the African Development Bank had about $6 billion available to countries for their healthcare. Not many people have tapped into it, but it's available in form of grants, some things that you can apply for, loans, bonds. There are many instruments that are available for countries if they take their healthcare serious. And then next, we need to think technology for universal health coverage. Technology, mobile apps, mobile phones, telemedicine, telementoring, use data. We need to collect data now for decision making. Next slide. And then we need to think of collaborating globally. You can't do it alone. There's something that is to be learned from the region. And I'm thankful for the work of PAHO, for instance, the Pan-African Surgical Healthcare Forum. WHO is getting acts together in certain areas and people are working together now. There are international partnerships, Global Fund, Gavi. People are coming together to tackle global health challenges. But we must that collaboration and address them if we really want to have universal health coverage in a sense in these member states. Finally, there's policy reform, or second to finally, policy reform. We need commitments from governments to prioritize universal health coverage in national health agendas. And I put here many national surgical healthcare plans. This is a commitment to surgical care on a broad level. At least the policy is there. Next, it needs to be implemented. So you see here from multiple countries, different countries, Rwanda, Senegal is there, Tanzania, Nigeria, Ethiopia has done this twice. So many people are thinking about their healthcare, thinking about universal health coverage. Next slide. So Ghana just recently released their national surgical healthcare plan. Botswana, Uganda, thinking about healthcare, global health, global surgery, specifically for pediatric populations, right? And this is a map of Africa showing, you may not be able to see all the nuances, showing the different countries and where they are in terms of thinking about coverage for healthcare, in especially the surgical plans, right? Are there policies in place? Are these policies on the shelf? Are they functioning? Are we executing them? Are we carrying them out? Are they expired? We need to think critically about political will, policy reform for universal healthcare coverage. Then finally, workforce and education development. We wrote a paper when we're launching our center on shifting the center of gravity of global surgical care. That's within global health. And one of the propositions that panelists made was, can we centralize certain things in terms of workforce and education? You can take a regional approach. It doesn't have to be only your country. If you don't have what it takes to be able to set up a cardiac center, can we select one country and make it a regional center for excellence in X or in Y, so that there's a lot of collaboration across the borders, and we can go there to get expertise. We can go there for training in this. It's the European countries use it in a business sense. There's that S3 S3 model, there are multiple things where you put supply in a particular place and you put things, strengthen what's going on in a particular place so that the whole region can benefit. So let's think about that. The West Africa College of Surgeons is doing that for West Africa. The College of Surgeons of East Central Southern Africa is also doing that. Next, I'll show you some cases, use cases of universal health coverage. So Rwanda, for instance, has made a lot of progress towards UHC. And how it does this is community-based health insurance. It's known as Mutuelle de Santé. It's community-based because it goes down to the grassroots. Every family pays a small amount. It's about 3,000 for each individual, and then it depends on how wealthy you are. So they separated the population into the wealthiest, those that are somewhere in the middle, those that are low, and those that are poor, and then the poorest of the poor. So taking those categories, the poorest of the poor may not even have to pay any copay at all, zero, and then they get help. Other people pay for them, and then the richest will pay, and then they will have a higher. So that's the way it is done. But it's available nationally from 2004. And there was healthcare services for the majority. In fact, the numbers should be about 97% of the country that is under some form of health insurance. And majority of that is the community-based health insurance. So there are premiums. Government subsidizes. There's international aid and donors that also help to subsidize. It covers basic health services and specifically pays attention to vulnerable populations, right? And Rwanda is also thinking training. There's this concept of 4x4. In the next 4 years, the country is committed to quadrupling, increasing the number of health workers by 4. So there's the 4x4 initiative, and it's very seriously being taken on all fronts. Medical schools, nursing schools, residencies, everything is being scaled up. Training is at a peak, and it's just started and gotten in. But the vision is that in the next 4 years, the healthcare landscape will change, and it has helped Rwanda achieve one of the highest healthcare coverage rates in sub-Saharan Africa, with reduction in maternal and child mortality, and there's increase in all the health outcomes you will see from the 1999 genocide against the Tutsi, 1994 rather, genocide against the Tutsi. All of a sudden, the markers have, like from rubble, the healthcare system has picked up and moves. But the challenge is that it relies heavily on international aid. Right, there's need for more financial independence, and if you want to sustain affordability for the poorest populations, right, and you want to maintain infrastructure, you want to maintain quality. When you're increasing workforce like that, you want to increase quality. Those are big challenges. Next country will be Thailand. In Thailand, next slide. In Thailand, they have been implementing comprehensive universal health coverage. They actually achieved universal health coverage in 2002, right, with the universal coverage scheme. And they finance it through taxation. It's not insurance premiums, it's taxation. And it will give most of the population free health coverage. But anybody who's in the formal sector, people who are in the civil service, they have a separate scheme. And the wins of the scheme, it has led to reduction in catastrophic health expenditures, especially for rural areas. Life expectancy has come up. The country has seen reduction in mortality from communicable diseases. But the challenge is also financial sustainability, right? Especially as the population grows older and the population ages. The population pyramid for much of the world is becoming top heavy. We have more people in the older population rather than a triangle like this. It's going this way, right? So we have more people they may not be as productive, right? There's rising costs for chronic disease management as we see ages of life expectancy improving, and people are now we're thinking, how can this be innovated, especially in cost management? How can we allocate resources better in this kind of situation? So that's the example of Thailand. The next is of Ghana. Ghana launched its scheme, the National Health Insurance Scheme, in 2003. And the focus was, can we reduce financial barriers to healthcare? Can we improve access to health services across the country? And its funding is not just from one thing. They're using taxes, deducting it directly from the payroll of workers. They're getting insurance premiums from individuals. So it's a mix of many things. And there's a broad access of healthcare services that can be accessed, including outpatient, inpatient, essential drugs. Its coverage for now is still growing, is about 40% of the population. I don't know if it's higher now, very recently, but the focus is, can we reduce out-of-pocket payments? Can we expand that cube, the coverage? It has led to increased access to healthcare, um, especially the rural population, improvements in maternal and child health indicators, healthcare utilization, because when people know I can walk into a hospital and get care, it has improved. But the issues, financial sustainability, inefficiencies, delayed reimbursements, when healthcare providers provide care, when do they get their money back? Where do they get their, and then informal workers who are not within government structures, poorest populations, and sometimes underinsured because they're not tied to the scheme in ways that other workers are. The final country would be Japan. Let's take Japan for instance. They had started their work in 1927. And so the point from this use case is it takes time to get to universal health coverage. It takes time. They had started 1927 and they achieved universal health coverage, very serious about it, in 1961. And they used a universal health insurance system that mandated health insurance coverage for all citizens through community-based plans and employer-based plans. So it was compulsory. And it's funded by contributions from employers, employees, government subsidies, and they can access a broad range of health care services, including preventive care like upper GI endoscopies, etc., because that's a challenge there. And they use regulated prices, which means that it's affordable. Now, the country has one of the highest life expectancies in the world, has high healthcare quality, but somehow, because of the regulations of the government, of the prices that people have to pay for this healthcare, right? They have kept healthcare spending under control, despite the fact that they also, like Thailand, have an aging population. But because of the strong government regulation of prices, they've not, they're doing better in terms of sustainability. However, there's still a lot of pressure. The challenge is, as the population grows older, there's pressure from increasingly older population, higher costs, demand for long-term care, and so they keep moving to more cost containment measures, more reforms in care to their elderly, and that's crucial if they're going to be able to sustain this universal healthcare. So, what is my summary? Next slide. One, that global health challenges are interconnected. They require collaborative efforts. So the concept of global health, I'm not giving you an academic definition. I've shown you multiple things that many of us have talked about when you're talking about this concept of global health, right? But the key takeaway from the definition of global health is that global health challenges are not just one. You can't just say, global health is HIV. And that's what we think. Oh, it's malaria or it's TB. It's interconnected. There are many infectious, many non-infectious diseases. It will look at the Marburg virus outbreak, for instance. It will affect the world if it were not controlled by the system, the strong healthcare system in Rwanda, right? The Mpox virus, if it's not controlled by strong healthcare systems, it will affect us all. COVID did the same thing. It undid a lot of things globally. Right? And it showed us that we are interconnected and we need to collaborate to address global health challenges. That's the first key takeaway. The second is that universal health coverage is not easy, but that's the goal. It's a vital goal. If we want to achieve equitable health outcomes all over the world, we need to think UHC. And it's not going to just be something we do here and now. Every country will have a different approach. We can't mandate that this is it and this works, right? In fact, I was at a presentation this afternoon where we're looking at Somaliland and looking at the healthcare access and availability. And one of the things that they saw is even pushing money to individuals or just saying the healthcare is available and free does not mean people still don't go into poverty. doesn't mean they still don't experience catastrophic expenditure from other expenses. And so if we're thinking universal health coverage, we need to start thinking beyond just, making a resource available in a hospital. That's a good place to start. But we need to think about, do some research, look at the whole chain, look at follow-up, look at prevention. We have to look broadly. If we're talking universal, it's a vital goal in achieving equitable health outcomes all over the world. So if we look forward, still in concluding, if we look forward, we will see that currently there is commitment from global leaders, international organizations, governments. People are thinking this is something that should be done, especially if you're looking at the SDG framework with which we're looking at universal health coverage, right? So that target 3.8, as a world, we're committed to it. We want to achieve global health coverage, including financial risk protection, access to high quality essential healthcare services, and access to safe, effective, quality, and affordable essential medicines and vaccines for all. Goal 3, we want to ensure health lives and promote well-being for all ages. But it's not enough to just sign a paper or just say it. This commitment requires addressing these barriers, improving global health outcomes, embracing opportunities, and learning from other countries. So I hope that this gives us a broad idea of what universal health coverage implies, of what global health itself is, of what the main challenges in the implementation of universal coverage is, and of a few successful policies and innovative models in different regions. Thank you so much, ladies and gentlemen. Over.
It was an awesome presentation with a lot of information. Thank you very much, Dr. Barnabas, for all the info that you've been giving us these past hours. And it's been great having you both. Thank you, Héctor, also. Muchas gracias por habernos acompañado. Realmente, como resumen, tenemos que entender que la salud global es un tema que nos va afectando a lo largo del tiempo. Ecuador está pasando por este proceso, por eso es que incluso ven mis pantallas en negro. Tenemos un proceso el que tenemos que llevarlo a cabo dentro de salud y dentro de todo lo que estamos acompañando en la construcción de la salud para la población, desde fuera de un punto de vista hospitalocéntrico, desde un punto de vista de la prestación sanitaria, y va mucho más allá. Entonces hablamos de procesos de prestación sanitaria, no son los únicos para alcanzar la salud en la población, y eso es lo que ofrecemos dentro de la maestría de epidemiología, en la cual trabajamos más bien sobre cómo construimos estos determinantes, cómo entendemos los determinantes y cómo entendemos la salud desde una teoría de sistemas y desde cómo el ser humano que pertenece a un sistema como tal se desarrolla dentro de este, y este va de una u otra manera a incidir en el proceso de salud de enfermedad de la persona, y sobre todo va a incidir en el proceso de calidad desde un punto de vista de vida, desde calidad de un punto de vista de su desarrollo individual, familiar y comunitario. Entonces, todos estos procesos son los que a la larga los vamos analizando dentro de la maestría, dentro de los 3 semestres, de los 3 semestres que los tenemos. Ha sido un gusto el poder contar con ustedes, con su formación y con todo su conocimiento. Les agradecemos muchísimo. Cami, no sé si es que hay preguntas, no encontré ninguna dentro del chat.
No, Doc, no tenemos ninguna pregunta hasta ahora. No sé, tal vez quienes están conectados nos pueden ayudar si desean. De igual forma está proyectado el QR para que puedan registrar su asistencia y poder emitir los certificados de participación.
Muchísimas gracias, Cami. Gracias a todos por acompañarnos el día de hoy. Ha sido un gusto el poder compartir con estos grandes panelistas. Agradecemos a la Corporación Latinoamericana para la Salud. Muchas gracias, María José, por habernos ayudado dentro de este proceso de formación, y agradecemos a los panelistas por habernos acompañado. Thank you, Dr. Barnabas. I know that it's really late over there, but we really appreciate all the information that you've been giving us, and it's a pleasure. It's been a pleasure to know you, and it's been a pleasure to receive all the lecture that you've given us, and I hope to see you again in the future. Igual, doctor Héctor, muchísimas gracias por su participación y esperamos volvernos a ver muy pronto.
Muchas gracias, doctores. Muchas gracias, doctora Flores. Siempre puse virtual a la orden para poder hacer estos eventos, los cuales suman mucho a nuestra maestría en epidemiología y nada, muchas gracias a todos los asistentes de igual manera.
Muchas gracias, que estén bien.
Un gusto, hasta
What a-
luego.
What
Buenas
a pleasure,
noches.
Dr. Barnabas. Take care.
Thank you so much, Hector. Great to see you here.
Great to see you as well. Take care. Take care.
Bye. Thanks.